Hi everyone, so I'm Cathryn Collins. So I'm a child and family health nurse as well. All child and family health nurses have to study at university to perform in the role. So I've done my diploma in child and family health, and prior to that I completed my paediatric nursing certificate through UTAS, University of Tasmania, and I've worked with families and children for about 11 years or so. It's one of the earliest places I started working on the children's ward, and then kind of realised whilst I was there that I was looking after a lot of really preventable diseases, illness, injury, and that led me to go and study my child and family nursing, and now I work in Bridgewater, which is about 30 minutes out of Hobart. It's quite a vulnerable population there, but having said that, it's a really diverse kind of mix of families, which is really, really nice. Yeah, and that's about it really. That'll do.
So Cathryn and I are going to be talking about some common questions that we get in the first 6 months of life, and a little bit about the Child Health and Parenting Service, which is CHAPS. Yeah. So, what do people know about the Child Health Service, and what do you think that the Child Health Service does? Does anyone have any ideas? Well, we're state-based, but we do, other states all have their version of either a maternal health nurse or everyone's called a little bit different, but ultimately our goals are the same, that we all support families and we all do screening and surveillance to make sure children are developing their kind of milestones. Yeah. Has anyone ever referred to their local kind of child health centre? Yeah. Yeah. And what kind of things would you generally refer for, do you think? Feeding?
Breastfeeding and introducing solids.
Yeah. Hearing assessments, yeah, absolutely. Yeah.
Very common thing for you always get.
Yeah. So, this is us getting prepared for our talk today. So the Child Health and Parenting Service work from the primary healthcare framework. We focus on health promotion and, as I said before, screening and surveillance. Our focus is the health, safety and wellbeing of the child. The child is our major focus, but we help support a family to get that child to have their ultimate development. We're a free service offered to all families, from mainly birth to 5 years old, but we do get some antenatal referrals for more complex clients every now and then. As we said before, that we're all registered nurses that have done an extra qualification in child family health. So whether that's a graduate certificate, graduate diploma, masters, we all have to have that little bit extra. There's 2 enrolled nurses that work in our state service, and they work through the parenting centre. And the parenting centre is just an extension of our service, which focuses more on sleep and settling, postnatal depression, behaviour management for toddlers as well. So they can refer themselves to the parenting centre, or they can get referred through by anyone in the community as well. Our service liaises with GPs, child protection, gateway services, social workers, mental health services, drug and alcohol, lots and lots of places that we can refer to. We also run new parent groups and help support families get connected with the community, because there's a lot of isolated families out there. We also run a See You at Home program, which is a teenage mum based program, which a lot of states have their own versions of that as well. So we generally see children within the first 2 weeks of life. We see them again at 4 weeks, 8 weeks, 6 months, 12 months, 2 years, and then we do a Healthy Kids check around about the 3.5 to 5 years, where we do the hearing and the vision assessment as well. We are also flexible with our times. We can see a family whenever they need to in this time. We're a free service, they can drop in. We run open sessions once a week, which run for an hour and a half, and it's just a drop-in session. They can come whenever they like, even if it's just to weigh their baby or if it's for more complex needs. So they're the ones that we're focusing on today. So some of the key topics that we discuss with all families over this time are all of these things. Some need more support on particular topics, and some you can just kind of glaze over for family. So it's very family dependent. But we will discuss all of these with each family that comes through our service. Cool. I'll pass you on to Cathryn for a bit.
So, fact or myth? Alan covered this one pretty much in his speech. For the first 6 months of life, a baby requires only breast milk or formula. Fact or myth? Yep. Yep. So the NHMRC, the National Health Medical Research Council. Oh, it didn't go. Oh, no, it did. Sorry. Yes, recommends to exclusively breastfeed the infant until 6 months of age and continue until 12 months or beyond. So whilst breastfeeding is encouraged, this may not be a possibility for for some mothers, and some mothers just choose not to breastfeed. CHAPS, or Child Health and Parenting Service, will support breastfeeding mothers and with their goal to continue to feed. But also support their choice if they wish to switch to formula. And to be honest, most families come and tell us they've made the change. Some families will engage and, ask for breastfeeding support. Some families just come and say, I stopped breastfeeding 3 weeks ago. So it's a little bit, I guess, if they're having trouble, sometimes it's hard because you feel like you could have helped to support them, but they've made that decision. So I'm not sure if everyone knows, but all formulas in Australia are made to national standards. They are all safe to give in Australia, but we as child health nurses do not promote a particular brand of formula or any particular brand of any baby product. If you're not really sure how to support a mother with breastfeeding, it is really good to refer to your lactation consultants in your local community, refer on to the child health nurse, and also you can refer parents to websites such as the Australian Breastfeeding Association. They also have counsellors and phone counsellors available as well if they're in a more remote area. And we've got some websites at the end that you'll find useful and lots of breastfeeding information on as well. So complementary or mixed feeding is safe as well. A lot of mums kind of get a bit confused. Can they give breast milk? Can they give express milk as well? Can they give breast milk and formula? Sometimes some mums are told you kind of have to give one or the other, or it's a bit confusing. So it's just nice to know that it's safe, as long as baby is getting fed, basically. And our, if we're not really sure if baby's getting enough milk, we just go back to basics, looking to see that baby is having wet and dirty nappies, looking to see that they are kind of gaining weight, their general appearance, are they pink, are they warm, or are they mottled and drowsy, lethargic. And jaundiced babies, they can remain jaundiced for several weeks after birth, and breastfeeding jaundice can be part of that, but probably won't go into that today. So what are some of the benefits of breastfeeding? Anyone?
Yeah.
Pardon, sorry. Immunity, yep.
Convenience.
Yep. It is easily digested, yeah, I think. Did you say that?
Balanced nutrition.
Yeah, yep. Very good. So here's a list of just some of the benefits of breastfeeding. Actually, I was talking to a midwife the other day and they said it was environmentally friendly, which I hadn't really thought about, but it's a big environmental, a lot of information at the moment. So at our initial home visit, which is usually at around 2 weeks of age, we complete an infant feeding assessment with all mothers and babies. So we do it initially at this time, but then it can be done at any time after that. We can do it weekly if we need to help support mothers with breastfeeding. It also looks at the pregnancy, the labour, because we know that there can be factors that contribute to successful breastfeeding. So it looks for possible complications. And we also observe a feed if we can. So then we're looking for positioning, attachment, suck and swallow, just giving general breastfeeding support and advice, and letting mums know that, and dads know, that feeding behaviours change over time. So a newborn will feed very differently to a 6-month-old. With positioning, we're looking for the rooting reflex. Does everyone know what that is? No? So you might, when you're holding a little baby, you might see that they open their mouth and try and latch onto your arm, which is a bit embarrassing when they do that. So that's a really strong cue. They open their mouth very wide and they turn in towards the caregiver's body. We look for nose to nipple. So the nose lines up with the nipple of the breast. A lot of mothers line up the nipple to the mouth, but we actually want to line the nipple up to the nose. We promote tummy to chest, so baby's tummy to mum's chest. We find a lot of women breastfeed with the baby sort of lying away from the nipple, so it is good to promote that tummy to chest, which creates a really nice alignment as well, and a nice relaxed posture. So there are many more keys that you can look for, but I guess if you just wanted a couple to look for, then there's some really good ones. We're looking for a really nice attachment. Do people know what to look for with attachment? Yeah, a few nods. Yep. So a nice wide open mouth where you see with that rooting reflex, and approaching from under the nipple, which is how we get that nose to nipple as well. And we're looking that baby takes a good mouthful of the nipple. Some babies just latch on to the very tip of the nipple, but if they do that, they're not actually allowing themselves to actually drain the breast. Sometimes that can also result in just comfort sucking, a bit like sucking on a dummy, just to help soothe baby. We also look that the lips are flanged out. This is a nice example of baby's lips here. So if they're tucked in like this, then that also will inhibit how well they can extract the milk. So a newborn baby might get very sleepy at the breast. That's very normal, but it's just we just encourage mums to continue to wake their baby, play with them, annoy them, I suppose, during the feed, and waking them every maybe 3 hours in the day and every 4 hours overnight. A 6-month-old baby will be interested in their surroundings, possibly more so than feeding, even though they want to do both at the same time. And that's where you see babies latching on, off, pulling away. It can be quite traumatic. So, just also normalising that feeding behaviour. And it's not that the baby doesn't want to feed or they don't like the mother's milk anymore. It's just one of those things that happens, and it will probably get worse. So just trying to feed baby in a quiet place with few distractions. And then we just look for comfort feeding. So, when a baby is just suckling at the nipple but not actively feeding, we want to see those good sucks and those good swallows. Comfort feeding over a long period of time can, then create sleep associations as well. So some women don't mind that, that's fine. But sometimes it can be a bit of a struggle when that becomes a dependent sleep association. I think someone in the room asked about, recovering from a cesarean and what advice do you give? Basically, the magic number is 6 weeks. So 6 weeks is when you return to, doing some of your usual activities, reaching to get the clothes off the line and picking up your toddler. But for that first 6 weeks, it's really important to remember that, especially if you've had a cesarean, that you've had major abdominal surgery. So it is really important to rest, eat good food, use your supports. I'm not sure about other states, but in Tasmania, we recommend to not drive your car for 6 weeks. Whoops, a bit loud.
Just going up a bit.
For 6 weeks after birth, and that can be around, actually having that control to be able to slam on the brakes, or what damage you might do if you're in a car accident to your cesarean wound. It's also got to do with insurance as well. Severe abdominal pain, lots of passing big blood clots can also be a cause of concern, so we would recommend that parents see their GP. In Tasmania, antenatally, women are referred to the community physiotherapist as well for follow-up, for pelvic floor follow-up mainly, to get exercises and things, and then it's a really good time to make women very aware of doing those pelvic floor exercises. At the 2-week check, we also do a family assessment. So this basically just provides us an opportunity to get to know families a bit better. Every family comes from a different background. It's nice to know where they've been and where they want to go. It looks at social supports, medical history, family history as well, childhoods, if there's any history of substance use. And people say, do people really tell you that they use pot or THC or, ice? But they do, and then that's an opportunity for us to be able to provide information if they do continue with these behaviours, how to do that safely. But we also monitor it very closely. It looks at history of current or past exposure to family violence, child protection involvement, or any concerns or services that are involved. So the 2-week check, this is what it looks like in our blue book, but it will look very different state to state. So at every child health assessment, we weigh baby, we measure them, see how long they are, we do their head circumference. We check that the soft spots have closed. The posterior soft spot is closing, the anterior one will stay open for much longer. We check that their eyes are focusing and not just darting around all the time. We look that they can respond to sound in each ear. We look at their mouth, their palate, check for femoral pulses, feeling for any hernias or lumps or bumps anywhere, looking for birthmarks as well, looking to see if the testes are descended, checking their hips for hip dysplasia, so we'll feel a click if there is any concerns. Babies have some reflexes at birth as well, so we need to make sure they've got those. We also talk about the newborn heel prick being completed as well, so we make sure all babies have had that at the in the first 2 weeks of life. We also talk about preventing a flat spot on back of baby's head, which we'll talk about a bit later. Sudden infant death syndrome, or SIDS, and how to reduce the risk, and also smoking. So SIDS, sudden infant death syndrome. Do you guys know much about how to reduce the risk, or is this? No. Yep. So in Tasmania, there was a big study done many years ago. We have one of the highest rates of SIDS down here, and so this is where these recommendations developed. So we recommend babies sleeping on their backs from birth in a safe environment day and night, so that might be a bassinet or a cot. Placing them so their feet are down the end of the cot or bassinet so they don't wriggle down, and blankets are tucked into about shoulder height. Keeping the face and head uncovered, so we don't promote the use of sleeping baby in a beanie or with toys or pillows, cot bumpers, big no-no. Sleeping baby in a smoke-free environment. Avoid co-sleeping with baby. There can be some cultural issues with that. And then, so sleeping in the same room as the parent, tucking and bedding really tight, avoiding the use of big feather doonas, and ensuring baby's dressed for bed. There's a really good brochure on the Red Nose website as well that we hand out. We talk about smoking at most appointments as well. So this is the advice that we do give. We also offer smoking cessation support. We talk about smoking safely with children because we know that smoking around babies will increase their risk of SIDS, also increasing their risk of childhood health illnesses and asthma, respiratory illness. So they're the main ones. Secondhand smoke is the smoke breathed into a baby's face like that picture shows. So if a parent or caregiver is holding a baby and smoking, that's secondhand smoke. Also if they're smoking in the same room or outside of baby's room, even if it is in the outdoor environment. Third-hand smoke is a new one that's being looked at and researched at the moment. So third-hand smoke is more looking at the smoke that goes onto your clothes, your skin, furniture in your house, paint, carpet, and that's actually then released for months over time. So that's why we talk about keeping them in a smoke-free environment. And I assume it's law in other states of Australia, but in Tasmania it is law not to smoke with an infant in the car, a child, even with the windows down. I'll hand back over to Jess.
Okay, we've got another fact or myth. So a baby cannot have tummy time on the floor before 2 weeks of age. What do we think? Show of hands for a fact. Show of hands for a myth. Yeah, a few myths out there, a few people unsure. So yeah, it is a myth. Babies can have tummy time on the floor or on adults' chest from birth. And that just helps with their gross motor and it helps with preventing little flat spots on heads as well. So, tummy time. So, as I said, we encourage tummy time when the baby's awake and as a playful activity. It's normally nice to do it maybe after a feed because that's generally when baby's most awake. Obviously, when they're first born, they're not going to tolerate a long period of time on their tummy. So it's just watching when baby starts to get a little bit fussy, then stop your tummy time. So it'll only be short amounts of time and then you build up gradually. You don't want to do it when baby's becoming unhappy. From 8 weeks, you can roll up a towel and place it under baby's armpits while they're on the floor so they don't have to use all their muscles and tire out really quickly. We do this to stop this nice little plagiocephaly, which we can see starting to have a little bit of a flat spot. So plagiocephaly is the most common craniofacial problem today, and I'm sure if you're working with children that you've probably seen a few misshapen heads out there. So it just means that it's a misshapen or uneven asymmetrical head shape. So you can get it from the side, you can get it from the back, you can get some strange ones. So what we encourage the parent to do is look straight down from the top of the head because then you can see the shape a lot easier. I've also suggested to a lot of families to take photos because then you can see if it's getting worse or better because it can change, you know, from week to week quite rapidly, especially in the early days because their heads are so soft. If at first sign of any plagio, we would encourage more floor time. We'd make sure that they don't have any torticollis, any stiffness of the neck, make sure that they can look both ways. We encourage some baby massage after a bath. And even simple things that sometimes parents don't think about. When they're holding their baby, if they hold them only on one side, then they're always looking out that one particular way, so encourage them to use both arms. If there's a toddler running around or something exciting happening, they'll look towards the excitement, so encourage them to go both ways. Putting them on the different end of the bassinet every now and then if there's something exciting happening, or even just light from a window, they can get attracted to the light, and all different types of things that you can try and say for them. So we will encourage that, and we check for plagio every time they come and see us, basically. So when we do our 4-week check, we do basically all the things that we do in the 2-week check with the development stuff. We rediscuss the SIDS and the smoking and encourage the tummy time. We remind them that their immunisations at 6 weeks are coming up and to make an appointment with their medical practitioner, whether that's a GP or their paediatrician. We also encourage mum to have a 6-week check either at the GP or obstetrician. And we discuss with the parents what kind of milestones they're looking for as well. And in our little blue books that we hand out, and they're different colours in each state, but they've mainly got different milestones for parents to look at as well. So, Wonder Weeks. Has anyone heard of Wonder Weeks, or is this a foreign concept to you all? Not heard? So Wonder Weeks is a term used to refer to developmental changes in the brain which leads to a new skill. So these states occur in regular periods with each baby in the first 2 years of life. So during these weeks, the baby might become a little bit more unsettled, have changes in their sleep pattern, cry more, be more clingy, have a bit of a reduced intake. And as you can imagine, that can cause a little bit of stress on the family. And if a baby starts not to sleep, then the family kind of goes, oh my gosh, it's going to be like this forever. So sometimes just normalising that can help reduce some parental stress. Obviously, if it's an ongoing problem, or if the baby continues not to feed well or starts, not putting on weight, then it's another problem. So normally a Wonder Week is followed by a Sunny Week as well. And so these are the weeks after the Wonder Weeks where the baby returns to their more usual behaviour, and normally we'll find kind of a new skill. So they can be even tracking you a little bit more, or just be a little bit more alert sometimes. So the Wonder Weeks normally happen around about 5 weeks, around about 8 weeks, 12 weeks, 4 months and 6 months. And the Sunny Weeks are kind of around the 6 weeks, 10 weeks, 3 months and 4 months as well. So Wonder Weeks are at 5 weeks, 8 weeks, 12 weeks, 4 months and 6 months, roughly. Sunny Weeks are 6 weeks, 10 weeks, 3 months and 4 months, kind of just after that Wonder Week at 4 months. You can get an app on your phone and it's free, and mums love it, and you can put your baby's date in and track it, and they'll be like, oh my gosh, it's doing this, and that can provide some reassurance for them as well. I think if you go, I don't know, do you know? It's just called Wonder Weeks. Yeah, I think it's just Wonder Weeks.
Yeah. But it's amazing how many parents say, spot on.
Yeah, it is.
This happened.
Yeah.
Mm.
Go over again some of their behaviours in a Wonder Week?
So they just become a little bit more unsettled. So sleep can go out the window a little bit. They can be a little bit more clingy. They can reduce their intake a little bit, or just be a little bit more fussy on the bottle or the breast. Cry a little bit more, just generally just a little bit more fussy. Yeah. What was that? Yeah, it's around about the time they have big growth spurts. Yes. Yeah, they like to change it. It's all around the same, but it's not just growth, it's development as well. So yeah, I think that's why they changed it. We also talk a little bit about a circle of security. Anyone heard about this before? No? This is just, it's about attachment to your child basically, and providing a secure base. for your child and to allowing them to explore their surroundings confidently. So just by creating a secure attachment is important for the child's development. It allows them to regulate their emotions and create relationships. And research shown that's most critical in the first 5 years of life, is to have a secure base. So an example of secure attachment, I suppose, is that at 6 months, if a new person is holding a baby and the baby hasn't met this person before, they'll generally notice that they're looking around for their caregiver and they're trying to find where, you know, mum or dad is and looking around. In older children, it can be like if someone's at a park and they're about to go down a big steep slide, they'll look back and see if their caregiver's freaking out, going, oh my gosh, or if they're like, yeah, go for it, and then they're a bit more confident to do so. So providing that secure base. And those with children may have noticed, like if a child goes out and play, they'll come back and show you something and then they'll run away and do something else and then come back and show you something, and that's all about the circle of security, about them letting to explore and coming back and providing that safe haven. Let's talk a little bit about that with parents. Then we do our 8-week check. So we rediscuss all those things again, we remeasure, we check reflexes, check development and all that kind of stuff. We also talk about SIDS again and smoking, and make sure they've had their immunisations done at 6 weeks, and that they've had a medical review as well. At the 8-week check, we also do a screening for postnatal depression. We don't do that just for mothers, we do it for fathers if they attend the clinic as well. And Cathryn will talk a little bit more about the postnatal depression screening as well, which you've got on your table that we do. Yeah.
Fact or myth time. Only mothers experience postnatal depression. Yes. Good. So the statistics at the moment, 1 in 7 women and 1 in 10 men experience postnatal depression. Have many of you worked with women with postnatal depression or in your clinics and things? Yeah. Maybes, yes, yep. So we've just got a few slides on what is postnatal depression, detecting it, and you know how you can help. So postnatal depression is anxiety and or depression which develops or changes after the birth of a baby. Risk factors, the main ones would be a family history of depression or anxiety. Traumatic birthing experience can put women at a higher risk. Relationship stress, maternal exhaustion, recent big life changes such as moving a house, changing a job, loss of a loved one, getting married, or even a relationship breakdown. But all of those ones listed there are all risks. Signs and symptoms. All of these are signs and symptoms that we look for. I guess the ones that we see the most are low mood and mothers expressing an inability to cope, feeling inadequate, worthless, helpless, overwhelmed, appear like they're close to tears or crying, fear of going out, fear of being alone with their baby, but also a fear of being alone with their baby, but also a fear of leaving their baby with somebody else, which there is a level of normality with that, but it's, a bit more. Having catastrophic thoughts, like not wanting their partner to go to work because they're just not going to come home. So, and that becomes a real mindset for some of these women. And that obviously increases anxiety. They might withdraw from friends or family. They might express thoughts of harm or just not wanting to be in this situation anymore. They might express thoughts of suicide or death. And they might, or men more so, might increase their risk-taking behaviours. And men also can show a little bit more aggression. So as Jess said, we conduct the Edinburgh Postnatal Depression Scale. We call it the EPDS. And that is routinely offered at 8 weeks. We will offer it at any time. We had a nurse just this week, offer it at the 2-week check because there was a lot of signs and symptoms and risks. And then with the questionnaire, which is on your table here, so these are the questions, we always ask parents to reflect on the last 7 to 10 days. So we know there can be a lot of changes and, you know, initially baby blues, but it's more when these symptoms have been exhibited for about 2 weeks. So it's a set of 10 questions, and have a look at question 10. I guess that can be a bit confronting, but yeah, it's around the safety of mum and baby and those around her. I guess in the GP clinic setting, you'd look to see if the parents are making eye contact with you, if they have a flat affect, or limited interactions with you or their baby. If parents do answer on question 10, yes, quite often, sometimes, or hardly ever, we do like to explore that a little bit more. Sometimes it is that parents, you know, they just want a break. They want to go away for a couple of nights, you know, kid-free, just sleep in. But sometimes it can be much more than that. So it is really important just to keep an eye on them. So treatment options. Number 1, self-care, self-care, self-care. Cannot express it enough. Women and men, but new parents are so busy giving so much to their child and, you know, meeting new parents, they're having family over, they often forget about looking after themselves, or they find it really difficult to find the time or the energy to do that. So we talk about creating really small goals. Having a shower can be a goal initially, but after the first couple of weeks, you might talk more about going for a short walk or finding some time to have a rest. Doing some drawing is really good as well, some meditative sort of colouring in books and things. That can be a good distraction. Yeah, so if a woman does, or a man, score highly on the Edinburgh scale, we would refer to their GP, and we'd also offer face-to-face or phone follow-up. So at the GP, we request that parents seek a mental health care plan, and also engage with a counsellor or psychologist, and sometimes medications are needed, not always. The child health nurses and at our parenting centre, and our programs run through parenting centres or similar centres on the mainland, do offer postnatal depression therapeutic groups, and it gives a lot of strategies, coping strategies, communication strategies, and works towards achieving some of those goals that keep getting pushed behind because they just can't get to them, they're not well enough. Then it's the 6-month check. So there's a bit of a gap. We discuss immunisations again, make sure that immunisations are up to date because they're due at 6 months. And we also introduce the concept of cleaning our teeth and gums and things. And also we introduce what we call the PEDS. So the PEDS is the Parents' Evaluation of Development Status. So it's a research-based tool. It's designed for parents to have a look at their child in lots of different domains of development, and it gives them the opportunity to list any concerns. Sometimes it's that they compare their child to another child and, you know, we just counsel them, provide reassurance. Sometimes it ends up in a referral to another service. So that's what it looks like. Yeah, so it is actually used for children up to 8 years, but in our clinics we use it up to 4 years because we stop seeing kids after about 5 years of age. But it suggests that if parents are asked an appropriate question in the correct way, they are very accurate observers of their child's strengths and weaknesses. So it's really important to listen to what they're saying here. Question 9, at 6 months can be a bit of a strange one. Most parents go, what? This is ridiculous. But this is when we really use this time to really name up attending playgroups, reading to children, singing to children, interacting, and really starting that educational journey with them. Oh, you can't read it? Sorry, I can read it. Do you have any concerns about how your child is learning preschool or school skills? Question? Up the back.
Oh, yeah, sorry, just a comment. So I do the head screening at work, and I was talking to my next door neighbour about it because she has a baby. She's a physio, and she was saying that actually with younger children, and when you ask families this question, it's useful to ask them things like, are they able to sit up? Because obviously when further down the track, they will need to sit still and focus on a task at school. So you kind of tie it into lots of the other milestones that you probably do ask about.
Yeah.
I was told before, it's about 20 pages of book and really big stuff you might say, but actually some of those growth skills are relevant.
Yeah, yep, that's right. Did everyone hear? Yep, very good. Thank you.
Oh, so when should an infant start solids? What do we think? Yeah. When they're ready. A few different things. I think we're all about right. So, how do you know when a baby starts solids? So the baby is around about 6 months of age. We say definitely no earlier than 4 months, but around 6 months is what we recommend. Baby showing a strong interest in foods. This one you've got to kind of tease out a little bit more with parents because they're showing a lot of interest in everything around about this age. So they'll even be like starting to grab out at food if they're with their parents when they're eating and that kind of stuff. They'll be able to hold their head up without support. They'll be able to sit up with support, so they'll be not quite sitting but almost there. And they'll have that increased control of their tongue, so that thruster reflex where they always stick their tongue out all the time, that decreases around that age as well. So around about 6 months we recommend. If a parent comes in and at the 6 month check and said we started them at 4 months, it's not a big drama. If someone comes in at 4 months and says we've started, that's okay as well. All we would say is just watch signs for tummy upset, maybe don't progress too quickly and just see how they go. This is our lovely little food plate. So that's basically we try and get them to cover a bit of each section of the food plate now. Avoiding honey and uncooked eggs, raw milk for the first 12 months. Increased textures. So a lot of parents start their children on the really thin puree stuff. Once they've got the hang of that, which normally doesn't take them very long, starting to introduce little soft lumps, and that's really good for their tongue muscles and their mouth muscles, and it actually helps their speech and development as well. So we try and increase the textures and to aim for finger foods by 9 months of age. Messy play is something that's hard for some parents to get a hold of, but it's a really important thing. Let them feel it with their fingers, put it in their mouth, that way they get the idea of texture. So it's all, food's about feeling it as well as tasting it and all that kind of stuff as well. We do have a few vegetarian parents that come through, and that's absolutely fine, as we just recommend high iron foods as a first introductory food. So you can get iron from other things. You can get them from your legumes and your pulses and your tofu based stuff as well, so that's fine as well. That's a parental choice, but it's also good to know no matter what food or what diet fad the parents are on, it's good to let them know that a child for their optimal growth needs a bit of a variety from all those food groups as well. Yep.
I had a mother who was they're Australian and Indian.
Yep.
And they were going back to India, and the baby was 6 months old, and she said, because their curries that they have here are the same as what her parents will be serving. And she said, will they have any detrimental effect? I said, that's an excellent question. I don't know what to say to her.
They can have any type of food.
Like the
No, so it can upset tummies if it's a really hot kind of and different spices. It just depends on the child as well. So I would just suggest to trial a small amount and see how they go, and maybe take some of the heat away with it, because it's going to be more the spice of it that can upset tummies. Yeah. It's not going to have a major, it's just not going to like it or get a tummy ache. It's not going to have a major detrimental effect. It's important to note as well that breast milk or formula is the main source of nutrition until a baby is 9 months. So when they start their solids around 6 months, you always recommend that you feed your baby milk first and then give them a half an hour or so and then introduce your solids. There's no guidelines on how much you give to start with. You can give it once a day, you can miss a day, it doesn't really matter. It's all about learning to play with that food first. And then around about your 9 months, you swap it and you do your solids first and then your milk later, and then it can, your milk can decrease, they can drop a bottle and all that kind of stuff as they increase their food. And you can introduce full strength cow's milk from 1 year of age. Yeah. Does that make sense? Anyone have any questions about solids? Because that's a big one that we get asked a lot about.
I've had a baby that just actually didn't go on to solids.
Mm-hmm.
And I was just saying, what would be the like time that you'd leave it before you take some action?
You would start working from them from the 6 month mark and get them to play with food first. I think the more you kind of force it, the less likely they're going to do it. So being able to play with it, smell it, touch it, because if they put their hands in it, their hands always go into their mouth as well, so they're going to get taste of it as well and they're going to get used to it. So that's what I would recommend, is that just play with it. Yeah. Yeah.
What's the latest on the introducing allergy?
That high allergy foods. If there's an allergy in the family and you're concerned, always seek medical advice first. You can always do the little patch test on a wrist or a lip, because if it's going to be a severe allergy, they're going to know pretty straight away. But if there's allergies in the family, go to your GP first. They can have nut pastes from 6 months. You can have eggs cooked all the way through from that age as well. I would always say give it early in the day to watch them. Yeah. And just make sure that you can be close. Like if they're, because we've got a lot of rural families as well, so introduce it when they're in town, so they're close too. Yeah.
Sorry, just to follow up on the lady asked there in relation to solids, and if they were, say, 12 months of age, and you thought that they weren't engaging in food that you would expect a 12-month-old to,
Yeah.
is that a point, or is there a point before there that you would refer on, or is there...
We have food play groups through St Giles, so I would probably refer them on if they're having problems before the 12 months. And it's not that common before 12 months that you get that. You normally get the toddlers and the little bit older children, that it's a behaviour thing more than a texture thing. And not all children are going to like all foods, and it's mainly sometimes it's a texture thing, and you can introduce a food, up to 15 times or more before a child's actually going to take it, just because it's a weird and they've never had it before, and it can be a strong taste or just a weird texture. So I would probably be referring to the child kind of food play group kind of, if they haven't really been interested in anything, just a little bit before 12 months, but I haven't had to very often. It's more the behaviour of the 2-year-old. They were eating everything and then all of a sudden they're not eating anything anymore. Yeah, which is a common one. And then it's talking about behaviours and not buying into that whole you must sit there and eat your dinner. It's more like, well, if you're not going to eat it, you're not getting anything else, and they'll eventually eat it and bringing back out that same food. And yeah. Is that right?
One quick question.
Yep.
Introducing solids. They used to say you introduce one food at a time,
Yeah.
so you can identify an allergy.
Yeah.
Do you still promote
No.
that?
No, because what they actually found was that increased allergies, because kids weren't getting a whole variety of foods, so they built up allergies because they weren't exposed to different food groups. So the chances are being allergic to a whole stack of veggies pretty low. So they've actually found that it increased allergies amongst children. So they've gone, just give them a whole variety of stuff. Yeah. And that's important to tell parents as well, because a lot of the books still say that one food every 3 days or something. Yeah. So, which brings us on to the next one. When do you start cleaning a baby's mouth? Okay. Yeah. When they get a teeth. Ooh. So, yeah, we recommend cleaning a baby's mouth at the first sign of a tooth or from around 6 months of age. So even if they don't have a tooth, you can wipe it over with a face washer.
So we organised a presentation way too long because we're really good at talking. So I guess we might just leave it open to you guys. We've prepared some segments on some milestones, the unsettled baby, and also some sleep advice. What would you guys benefit from for the last 5 minutes or so?
Somehow I knew you were going to say that.
So, yeah, so we can cover a bit of all of it all together if that's okay. There is an activity that we gave you about milestones, but perhaps that can be some homework. I'm not sure if all of you got one. Just looking at different, so just hand them around. Oh, good, yep. So maybe just have some homework to figure out when kids do those sorts of milestones. We really like this picture. So,
Do you want to do the sleep one?
might do the sleep one, and then if we have time, we'll go back to the others. So sleep and settling, biggest topic of all for all parents. Shouldn't have left it to last, but we did. So who's tried Googling sleep suggestions, or who's looked in a bookshop and gone, how do I make my baby sleep? Yep. So it's quite overwhelming, the advice that you can receive and also what literature is out there. So sleep is important to caregivers and to babies. So sleep in babies allows rest, growth, development. Sleep in adults allows rest, rejuvenation, mental health regulation and energy. When a baby does not sleep, they get overtired and difficult to get to sleep. In babies, sleep promotes more sleep. When a caregiver does not get sleep, they become irritable, unable to cope, and everyday tasks become really difficult. And it contributes to maternal exhaustion, which can then contribute to feelings of postnatal depression. So it's important to emphasise using the supports, especially during difficult times when baby's really not sleeping, because we know that it does take a village to raise a child. Oh, 1 minute, good. Good, so, my picture hasn't come up, but basically children have sleep cycles of about 45 to 55 minutes, much shorter than adults. And then depending on what happens after in different intervals during sleep will depend on if that baby is able to actually transition to the next sleep cycle. Sometimes baby needs some gentle comfort, a pat, a rock. They might need a pickup and some reassurance. You cannot spoil a baby under 3 months. And that's a really important message. We get that all the time. Parents come in and saying, I can't hold my baby to get them to sleep because I'm spoiling them. But in actual fact, we talk about responding to your baby's cues, understanding their tired signs, getting to know them, and responding to early tired signs so it is easier to get them to sleep. Some babies just need to be on a parent. They just need that reassurance, but closer to 6 months, it's good to work on some other strategies. Is that it? Yep.
But you can include chat on the website. Is that all right?
Yeah.
Please come again.
Yeah. So they're just some tired signs as well. That's really good to observe. So yeah, closed fist, back arching, frowning, disinterest, hiccups. We talk about feed, play, sleep as well, not feed, play, feed, sleep. And these are the resources. Yeah. So these are all the resources we would recommend having a look at. They're all updated regularly by health professionals in those particular fields, and they're the ones that we give our parents to. Thank you. Sorry.
Great effort, Cathryn, and thank you so much. You guys are so passionate and certainly experts in your field, and we certainly value your valuable presentation today.